present today. So today I'm presenting the paper on COVID-19 vaccine intentions in South Africa and the health communication strategy to address vaccine hesitancy. So this paper is part of the NIDS-CRAM policy paper series, and this relates to the wave 4 output. Now, typically, when you introduce a topic for presentation, one has to, in some sense, justify its relevance. At least from that perspective, my job is easy today, given that we are in the midst of the wave 3 surge, and the ongoing pandemic, which has changed our lives for over a year now. There is, I think, very little need for me to address the issue of relevance of the topic. But just to again emphasize, we had on Monday a daily infection rate of over 12,000 new infections. And this is certainly lower than what we observed in the previous week, where the daily infections were closer to 20,000. And perhaps this reduction could be temporary, the Monday or the weekend effect, and the effect of the stricter lockdown measures announced by President Ramaphosa recently. But nevertheless, it is still worrying that the positivity rate continues to be over 30%, and the country has recorded new deaths of over 300 as of Monday, and that takes the total death toll to over 62,000. So given those facts, there is absolute clarity that preventive measures against infections are of utmost importance. So in the initial phase of the pandemic, the emphasis was primarily on the non-pharmaceutical interventions, and the emphasis in communication strategy at the initial phase was in creating awareness. These strategies emphasized at that point, or the initial point, was hand washing primarily and physical distancing. And then subsequently, we see that the use of face mask gained much more relevance and emphasis with the scientific evidence emerging on the airborne nature of infections. So our studies from the middle of 2020, that's May, June, July, August 2020, we see that the compliance in the use of non-pharmaceutical interventions was quite good to begin with, at 92%. And it in fact increased further in July, August to about 97%. So those were the initial preventive measures emphasized at the beginning of the pandemic. And towards the end of 2020, when vaccines started getting developed, there was obviously a shift towards vaccines as preventive strategy. Now, the issues relating to vaccines are slightly different from that of NPI, because adoption depends on availability and accessibility. And this has clearly been challenging for developing countries, and particularly for Africa, and including South Africa. But accessibility apart, the question of acceptance has also gained prominence in both developed and developing worlds. And this is because the secondary effects of vaccine require much more trust to instill a health behavior response as compared to non-pharmaceutical interventions such as the use of face masks. But what is worrying is that access has not been even across the various countries. And South Africa, as we speak, has vaccinated just around 3.3 million out of its 60 million population. And the population that has received at least one dose of vaccine in South Africa is still well below 6%. And compared to the global average of 24%, we can see that South Africa is way behind. And way behind not just compared to developed countries, but also far more populous countries like India as well as Brazil. So access apart, what is also worrying is acceptance of vaccine in South Africa. As you're aware, vaccine registrations were opened up to individuals over the age of 60. And what we see is that registration has hovered around 52% within that age group. So this is way below what one would have liked. And as much as one can point to challenges relating to the EVD, the transportation issues to the vaccine centers, etc., what ironically one can see from official data is that vaccine registration among the 60 plus age group is the highest in the most poorest or backward of our provinces, which is Limpopo. So Limpopo has registration rate of over 70% compared to a national average of 52%. And the Health MEC of Limpopo has highlighted the role of community and health worker interventions that has enabled this. But the point remains that the uptake of vaccine has not been as high as one would have liked across the country. Now, similarly, the vaccine registrations has opened up for teachers. And in particular, the Gauteng Education Department has come out expressing its concern with teachers turning down the opportunity to accept vaccines. So this highlights that South Africa faces a dual challenge of accessibility as well as acceptance. So it is within this context that we study the level of vaccine hesitancy in South Africa with a view to identify the socioeconomic patterns in vaccine hesitancy in order to develop a targeted health communication strategy. So the framework of analysis that we use for the study is fundamentally the health belief model and the extended parallel processing model. So the health belief model, which has existed for a very long time, has been used to predict health response behavior based on 4 pillars. Risk perception, which has 2 legs, which is vulnerability or susceptibility, and the other being the severity of risk, and efficacy and barriers to behavioral response. Now, the EPPM model adds to the health belief model by proposing that the effect of risk perception on health response behavior is mediated through the efficacy. So 2 possible outcomes exist under EPPM even within perceived high risk. So that would be high risk, high efficacy, which is the responsive group, and the high risk, low efficacy, which is termed as the denial group. So one of the implications of this is the recognition that greater fear through high risk perception does not necessarily lead to behavioral change, but can perversely cause message rejection if efficacy is perceived to be low. So therefore, identifying the risk-efficacy interaction is relevant in tailoring the communication strategy aimed at improving health response behavior. So here we have summarized the EPPM outcomes through the interaction of risk and efficacy. So we have the high risk, high efficacy category, where individuals perceive the risk of infection is high, but also believe that the severity or the danger from the infection is high, together with high efficacy or the belief that the infection can be avoided due to effective solutions and one's ability to adopt these solutions. So this category is the responsive group, where people are both educated about risk and respond by taking protection. So when high risk is compounded with low efficacy, we have the denial group, where people are aware of the risk, but feel helpless to respond effectively. And this category shies away from adopting preventive measures. And then we have the low risk category, where the belief is that the risk of infection is low or the severity of risk from infection is low. The individuals are not interested really in responding because the perceived risk is low, and the efficacy really does not, or perceived efficacy does not really come into consideration due to low risk. Now, the studies on COVID behavioral response are fast emerging within these two frameworks of health belief model and the extended parallel process model. But many of them have been concentrated on the non-vaccine behavior or the non-pharmaceutical interventions. Our own study, Kollamparbil and Oyenubi 2021, looked at the non-pharmaceutical intervention behavior within the HBM framework and identified that the predictors identified by the model, which is vulnerability to infection, severity of infection, as well as efficacy, are important predictors of behavioral response. But when it comes to vaccine behavior, we see that literature is far more scarce. And the only ones identified within the EPPM framework is in the US context by Chu and Liu 2021. So we have not been able to identify any study in South African context within either the HBM or EPPM framework that deals with vaccine behavior. The data for the study is primarily the fourth wave of the NIDS-CRAM survey. NIDS-CRAM, as you're aware, is a subsample drawn from the fifth wave of the NIDS 2017 survey. The sample size is far lower than under the NIDS survey. The fourth wave of the NIDS-CRAM survey constituted about 5,629 individuals. It was conducted over February and March 2021, mostly February. You see 96% is under February, wherein the country was under adjusted alert level 3, when curfew restrictions were imposed and businesses had to adhere to regulations in terms of the number of people allowed on their premises. This was eased from the 1st of March, but as you can see, only 4% of the sample is from March, and most of the sample is drawn from restricted lockdown levels. And the reason we focus on the fourth wave for this particular study is because for the first time in NIDS-CRAM, the survey instrument introduced a question as to what extent do you agree or disagree with the statement, if a vaccine for COVID-19 were available, I would get it? So the vaccine-related questions were not in the questionnaires in the first 3 NIDS-CRAM waves, and it was for the first time introduced in wave 4. The possible response to this question was on a 4-point scale of strongly agree, somewhat disagree, and strongly disagree. So a second relevant question introduced in the 4th wave of NIDS-CRAM relating to vaccine is, what is the main reason why you would not take a vaccine for COVID-19? So this study is fundamentally, or the outcomes of these studies are fundamentally drawn from or using these 2 questions. Equally important variables in line with the health models is to derive the risk perception and efficacy variables. So the risk perception in terms of susceptibility or vulnerability is drawn from the binary response of yes or no to the question, do you think you're likely to get the coronavirus? And the severity of risk is proxied using age, measured in years, given the evidence that the morbidity and mortality rate increases with age for COVID infection. And a second proxy used for severity of risk is prevalence of chronic illness. Again, a binary response to the question, do you have any of the chronic conditions? And it lists a few relating to the heart, high blood sugar levels, etc. The efficacy variable is sourced again from a binary response to the question, can you avoid getting coronavirus? Now, this particular variable is less than optimal in the study context because the efficacy question does not relate directly to vaccine. All it question asks is, can you avoid getting coronavirus? And because the survey was implemented before vaccines became widely available in South Africa, the fair assumption is that the responses to the question, can you avoid getting coronavirus, is not likely to refer to vaccines. And therefore, we additionally make use of the question, what is the main reason why you would not take a vaccine for COVID-19, to create a vaccine-specific efficacy variable. And the variable takes a value 1 if ineffectiveness of vaccine is not a response to this particular question. So the NPI efficacy and vaccine efficacy variables are interacted to create a combined measure of efficacy for the purpose of the study. The other important variable from the health model perspective is barriers of feasibility of behavioral change. And in order to incorporate the ease with which an individual can respond, the basic assumption made is that one has to be aware of the intervention required, and awareness is likely to increase with education. So education is taken as a proxy for a lower barrier to behavioral change, together with household per capita income and other proxies for socioeconomic status, such as whether the household has experienced hunger recently, whether there are grant recipients in the house, the nature of the dwelling, etc., are also included in various specifications of the model. Lastly, we include a set of control variables to incorporate the context within which the individual or the respondent operates. And these include variables such as the sex, included as male in the estimation, race, included as Black African, partnered, either married or in a relationship, the nature of location, which is urban here in the estimation, level of religiosity is also included to get a clearer picture of the range of possible predictors. Of course, we are limited by what the data that is available offers. But one particular limitation that needs to be highlighted is that we use self-reported data. And given that there is possibility that one cannot rule out of strategic bias in response, typically relating to NPI behavior and vaccine-related questions. So these are limitations that we have to work with. Having said that, NIDS-CRAM remains the best possible source of nationally representative data in South Africa to study COVID-related socioeconomic behavior. So moving on to the initial results. The response to if a vaccine for COVID-19 were available, I would get it. Like we said, there are 4 possible responses, which is strongly agree, somewhat disagree, and strongly disagree. 55% of the population, this is weighted. So we refer to this as the population of South Africa. 55% of the population expressed strong agreement with vaccine acceptance. Now, if one combines those who strongly agree with those who somewhat agree, which is 55% plus 16%, the vaccine acceptance is around about 71%. This, I have to emphasize, is for February, March 2021. Sorry, this needs to be corrected. This is February, March 2021. And the reason why I emphasize this is, as many of you may be aware, the NIDS-CRAM 5th wave has been completed. The data analysis has been done and reports have been submitted, but the report is embargoed until the 8th. So I'm not at liberty to share the latest information. All I can say is there is some mild improvement from the figures that we see here. But based on February, March 2021 data, vaccine hesitancy, which is defined as those who strongly disagree against getting the COVID-19 vaccine, and those who somewhat disagree on getting the COVID-19 vaccine, constitutes about 29% of the population. Now, comparing vaccine hesitancy across socioeconomic groups, one can see that straight away there is significant differences across various groups, sex being one of them. You see female vaccine hesitancy is higher statistically than male vaccine hesitancy. And this is significant at 95% confidence level, whereas the difference between African and non-African or non-Black African, you can see is significant at 99% confidence level, with Black Africans having lower vaccine hesitancy compared to non-Black population group. Similarly, you do see that those with tertiary education have lower hesitancy compared to those with education achievements below tertiary levels. Comparing across other categories, the major difference to highlight here is the difference between those with chronic illness and those without chronic illness. As expected, you can see those with chronic illness have higher vaccine hesitancy, and this is to be expected relating to the severity of the risk perceived of infection. But we do not see significant differences across employed or unemployed, urban or rural, awareness levels, and the other categories such as religiosity. Coming to the variables of our interest here, which is the risk and efficacy variables, it's interesting to see that the level of the risk perception, those who perceive higher risk have significantly lower vaccine hesitancy compared to those who perceive low risk of infection. But the difference is even starker when it comes to efficacy. So those with high efficacy have much lower vaccine hesitancy, even compared, not just compared to those with low efficacy, but even compared to those with high risk perception. Now, looking at the interaction between risk and efficacy using the EPPM framework, you see the responsive group being those with high risk perception and high efficacy have even lower vaccine hesitancy. And this is compared to the denial group being those with high risk perception but low efficacy. So you can see that these variables, risk and efficacy, are strong drivers of vaccine behavior or intention. Looking at some of the other continuous variables, such as income, age, and education, and we use the Erriger's concentration index to identify the inequality in distribution of our interested variable, we see that vaccine hesitancy is concentrated, is negative, indicating that it's concentrated among the younger population groups. Risk perception, on the other hand, is concentrated among the older age groups, the higher educated, and the higher income level. Efficacy, we see, is significant and concentrated among the higher education groups. So we do see that income, age, and education are correlated with vaccine hesitancy, risk, and efficacy. Moving to the question on reasons for vaccine hesitancy, we see that concerns regarding side effects is the single largest reason cited. 30% of those hesitated against vaccine acceptance reported side effects as the reason for vaccine hesitancy. Now, combining this side effects with the second biggest category, which is those who believe vaccines to be ineffective, you will see that about 50% are accounted for by side effects and ineffectiveness of vaccine. This clearly points to the need to address these issues among the public to ensure that information provided or accessed by individuals are genuine and reflective of the risk benefits of COVID-19 vaccine. And that clearly comes out as one of the strategic interventions required in terms of improving vaccine acceptance. Moving to multivariate analysis using the health models. The first three models in the table here are the health belief model, where we see risk perception and efficacy entering as binary variables. And models 4 to 6 are the EPPM model, where we have the categories low risk, denial, and responsive, which is the base category. So what is very clearly emerging from these results, where risk perception and efficacy in the HBM model contribute or are negatively associated with vaccine hesitancy, as predicted by the model. So those who predict higher risk are less likely to be vaccine hesitant. Those who believe in the efficacy are also likely to be less hesitant. Similarly, severity of risk is also an important predictor, with age being negatively correlated with vaccine hesitancy. We do not see the significance of chronic illness here, but there can also be some level of correlation between age and chronic illness. But the barriers as well, you can see education is again a negative predictor of vaccine hesitancy. Now coming to the EPPM model, we see that the argument of Witte 1992 and 1994 that efficacy mediates the relationship between risk perception and behavioral change is supported by our results, where compared to the responsive group, which is high risk, high efficacy group, the denial group has higher level of vaccine hesitancy. Similarly, the low risk group has higher levels of vaccine hesitancy. This clearly points to the relevance of the mediating role of efficacy in determining the risk perception effect on vaccine intentions. We are not able to see any strong relationship between income and vaccine behavior. To continue the variables here, none of the socioeconomic status variables are found to be significant, but we do see that the indications found in the descriptive statistics still hold in the multivariate setup here, where Black African population group has lower hesitancy compared to the non-Black population group. Another interesting finding coming out is the NPI behavior is closely associated with vaccine intention as well. So the NPI here variable constitutes of the number of non-pharmaceutical interventions adopted by an individual. So the more number of NPI measures adopted by an individual is negatively associated with vaccine hesitancy. Similarly, we see that the male sex has lower vaccine hesitancy under the HBM model, but it does not figure as being significant in the EPPM model. What is surprising here, all of these are in line with expectations, except the results of the partnered variable. The expectation would have been that partnered variables, individuals who are partnered, would have lower vaccine hesitancy, as literature indicates they are more risk averse compared to single individuals. But here what we observe is that partnered individuals seems to be positively associated with vaccine hesitancy. So discussions on that is something, and inputs on that is something I would welcome from the floor. Right. So the earlier analysis was on the binary outcome variable of vaccine hesitancy. So as a robustness check, we now undertake an ordinal logit estimation where the outcomes of vaccine intention are categorized as those who strongly accept vaccine, somewhat accept vaccine, somewhat reject vaccine, and strongly reject vaccine. So I do not want to dwell too much on this, except to say that the results from the logit models are validated through the ordinal logit marginal effects as well, where you can see that those with high risk perceptions are positively associated with vaccine acceptance, whereas high risk is negatively associated with vaccine rejection. So you see this consistently across the HBM model as well as the EPPM model, and the findings regarding efficacy as well as the severity of the risk are in line with the earlier results that we discussed. Right, so having identified that the predictors based on the health models are significant drivers of vaccine intention, next we try to identify the correlates of these population groups, the population groups who fall within the denial category, who fall within the low risk category, benchmarked against the responsive category, in order to target communication for improving vaccine acceptance. So in terms of the low risk category, what comes out significantly is that age decreases the probability of falling in the low risk category compared to the responsive group. But it's not a linear relationship where you see the age squared has a positive relationship with low risk category. So this indicates that although the probability of falling in the low risk category reduces with age, the elderly seems to belong to or have higher probability of belonging to the low risk category. Similarly, education reduces the probability of belonging to low risk category vis-a-vis the responsive group. Married or partnered status reduces the probability of falling in the low risk group. And we see that the employed, as well as those with higher levels of household income, are less likely to fall in the low risk category compared to the responsive category. When it comes to the denial group, there are very few significant predictors, but what stand out is the Black Africans group have lower probability of being in the denial group compared to responsive group, and the variable religious, those who consider religion to be important, have higher probability of belonging to denial group. So this is interesting. That would be the category that perceives high risk, but efficacy to be low. So these are important socioeconomic correlates of the different categories, which can now inform us in terms of the communication strategy recommendations. So what we have seen from the analysis thus far is that the responsive group are those with higher levels of education. They are older, they're married or partnered, and well informed about COVID. So that is the profile of the responsive group who believe that risk is high, but also that efficacy is high. And 40% of the population fall within this category, and vaccine hesitancy is lowest in this category compared to the other categories of denial and low risk. So the strategy for this particular group is the least challenging. It's basically to make vaccines available and accessible and provide clear information on the vaccine side effects and its effectiveness. So this is the least challenging of all the groups that need to be addressed. The low risk group is the biggest group, with about 53% of population fall in this category. And the profile of this low risk group emerging from our study is they are young, with lower levels of education, have single status, relationship status, are less informed of COVID, and belong to lower per capita household income categories. And the vaccine hesitancy is highest within this group, being 31%. So the strategy to educate for this low risk group would be to highlight the risk and through fear messaging, followed by risk and protective danger control through awareness about solutions. Once again, the need to provide more information on the COVID vaccines would also apply to this category. Lastly, coming to the denial group, which constitutes of people who perceive the risk but feel helpless to respond effectively because they do not believe in the efficacy of the solutions available. A small group of people, 7% of population, fall in this category. Vaccine hesitancy is higher than the responsive group, but low. So the strategy is less on fear messaging within this group and more on, the efficacy. And efficacy, because religiosity is a significant characteristic emerging of this group, messaging through religious institutions, church leaders, etc., can be considered as effective strategy. So in conclusion, vaccine acceptance in South Africa is found to be substantially lower than the non-pharmaceutical behavioral response observed. Our study validates the health behavior models as predictors of vaccine intention. Risk, both vulnerability and severity, are key driving factors, but efficacy plays an important mediating role, and this study validates the EPPM health model framework. The group that has seen to be most accepting of vaccines are those that perceive high risk as well as high efficacy. And doubts about vaccination and its effectiveness has emerged as key reasons against vaccine acceptance. Therefore, widening vaccine acceptance requires a three-pronged health communication strategy being put in place that targets fear messaging to the young, less educated, less informed, lower income individuals, and efficacy messaging to the non-Black individuals and the religious. And lastly, I would like to emphasize the need to address concerns on side effects and effectiveness of vaccines in all health communication strategies. Right, with that I end and hand over to Nerivia.